Thank you very much for inviting me today, and I look forward to telling you a little bit about painful beginnings. So pain is fundamentally protective. It's there to prevent us damaging injured limbs, it stops us walking into danger, and it teaches us about how to avoid potential dangers. But that's certainly not what you think about when you imagine a newborn baby. For me, I imagine a child in the arms of a mother, siblings, grandparents, being looked after at home. But it's simply not the case for the 1 in 7 babies that are admitted to hospital after birth. In this case, the babies have approximately 10 painful procedures per day, and for these procedures, pain relief is very rarely provided, even though we know that there are long-term consequences of early life pain. So I was writing a review recently, and I happily started writing, "Predisposition to undertreat pain still remains in clinical practice." And I thought I'd better do a quick reference check. So I went back to a source that I'd looked at almost 10 years ago, where the NHS Choices had said for tongue-tie surgery that being cuddled and fed is more important than painkillers. However, I then saw the update for 2022 that says the baby's head is held securely while sharp, sterile scissors with blunt ends are used to cut the skin. In very young babies, those only a few months old, the procedure doesn't seem to hurt. In older children and adults, it's usually done under general anaesthetic. So I was happily able to reference my statement that there's a predisposition to undertreat pain. So where has this come from? Why did we have this historical misconception? So I'm going to take here, it's an extract from some writing from a parent, Jill Lawson, who was a mother of a premature baby who died 5 days after surgery when the child was having heart surgery. And in this extract, she wrote that the anaesthetist used curare, which is a muscle relaxant, in order to immobilise the child, but the child was totally conscious. But then she asked the anaesthetist why this was the case, and they said it has never been demonstrated that premature babies feel pain. So what was happening and where did this idea come from? Well, this is an example of one of the many experiments that were conducted at the time. So in 1962, a rubber band was stretched, they say, by 7.4 centimetres to 23 centimetres using a gun-shaped apparatus, and it was flicked repeatedly at the child. And they concluded that the children who were less than 4 days old didn't seem to respond as quickly, and they seemed much less responsive than the older children. So this led to a whole history and conclusions around maybe infants have immature nervous systems. Maybe their lack of memory from childbirth somehow equates to a lack of experience. There are perhaps protective mechanisms there to make sure we're okay when we're first born. And certainly the reflexes that we can see do not represent the pain experience. However, Dr. Seuss had far better words of wisdom that he wrote in a children's book at the time. I thought this poem was fantastic, so I'll read it to you. Now the news has arrived from the Valley of Vale that a Chippendale mup has just bitten his tail, which he does every night before shutting his eyes. Such snipping sounds silly, but really it's wise. He has no alarm clock, so this is the way. He makes sure that we'll wake at the right time of the day. His tail is so long he won't feel any pain till the nip makes the trip and gets up to the brain. In exactly 8 hours, the Chippendale mup will at least feel the bite and yell ouch and wake up. So clearly Dr. Seuss had other ideas compared to the results of the experiments that we were seeing. So then there was a seminal change in clinical practice. Dr. Sunny Anand was a Rhodes Scholar who came to Oxford University, and he developed a rationale to justify that post-operative analgesia would be appropriate for neonates. I was recently reading his memoirs that he wrote a couple of years ago, and he said that for him the biggest success was that an Indian turban-wearing student was enabled to convince 56 anaesthetists in order to change their practice. And in 1987, indeed, they did publish the study in The Lancet to demonstrate that outcomes were better in babies who were given pain relief during surgery. This led to official investigations by the United Kingdom General Medical Council, and supported by the parent advocacy, practice simply changed. This is an example of one of the surveys that were done just to demonstrate how quickly the change occurred. In 1988, while 10% of anaesthetists only provided systemic opioids during major surgery, by 1995, this had gone up to 91%. So what's the problem? Where does this come from? Well, simply, it's that babies can't talk. They can't tell us when they're in pain. They can't tell us whether the drugs we're giving are helping them. And instead, we have to rely on surrogate indicators, such as changes in facial expressions, in order to assess their pain. But this is a problem because these indicators are not sensitive enough, and nor are they specific. They will show exactly the same kind of responses if they're hungry, if they're cold, or if they want a hug. And so if you're reliant on these kind of measures in order to better measure pain, you can come to erroneous conclusions. Some of the ones highlighted here are the main ways that we currently measure pain in the clinical practice. So what have we done? We thought perhaps one of the best places to look in a non-verbal person is the brain, because this is the place where the perception of pain occurs. So we've used a number of techniques, including near-infrared spectroscopy, EEG, and magnetic resonance imaging, to see what happens in the brain when you do something painful to a baby. And what you can see is there's a change in brain activity in response to these procedures. So when this was published in 1996, the worldwide media said babies experience true pain. Well, whilst that was one conclusion that could be drawn from this, in reality, this was still very much just the beginning. All we had shown is if you do something to stimulate the foot, that signal will be sent to the brain, even in the youngest and most premature infants. So what do we do now? There are three core aspects to this work. We use brain imaging and try and develop bespoke methods for neonates so we can better acquire and analyse data. We look at basic neuroscience. How does the human brain form such that we have the ability to experience pain in contrast to other sensory stimuli like touch or other experiences? And importantly, can this be clinically translated? Can we take endpoints using brain imaging in order to test the efficacy of drugs, assess the impact of comforting interventions, and ideally use these results in order to gain regulatory approval for these brain-derived measures so that we can start to actually test these drugs? So how do we do this? Oh, perfect. So a team of doctors and nurses on the neonatal unit at Oxford are able to record patterns of brain activity during painful procedures. They can place electrodes over the head of the infants while they're in their hospital beds, and in response to noxious events that happen in these children's lives, we can start to look at the changes in brain activities that occur. We can also take these children over to other imaging centres. So this is the Wellcome Centre for Imaging that's over on the John Radcliffe site, and we can start to look at the other organisation of the brain, and we can see what happens when we apply a nociceptive stimulus to all different aspects of the nervous system. And in doing this, we hope to better understand what's happening when a child experiences pain. So since these early days in 1996, or was it 2006? Yeah, 2006, I've just added on 10 years there. What have we been doing? Well, we were able to take these first recordings and actually use them as endpoints in clinical trials in order to assess the efficacy of drugs. We've been able to look at what's happening in the brain using MRI to get a much better understanding of the spatial organisation and the structural and functional way that this information is processed. We can start to ask questions. For example, how does individuals vary? Why are some children so much more responsive than others? We can look at the impact of inflammation, and more recently, we've been able to take adults, infants, and other species to look at the similarities in concurrent mapping across the species. So what are we doing? Last year, we published a Lancet Child and Adolescent Health Commission. And the aim of this was to really get information to charities, to stakeholders, to industry, to public people about the importance of trying to better be aware of pain in this population. We wanted to make pain matter, make pain visible, make pain understood, and make it better. And it was simply a remarkable thing, because after a few months of this being published, despite the other worldwide problems that were going on related to vaccines, the NIHR put out a call specifically for the pain management of children and young people. And now, in collaboration with Sam, and we just heard speaking earlier, and other colleagues in the Oxford Vaccine Group, we're going to go to attend this call and try and look whether we can reduce pain during vaccination. And this is really timely because it's also on the back of a WHO statement saying there's really no need to just say it doesn't hurt. We might be able to find other ways to better manage this pain. So I was asked to think about where we'd be in 50 years' time. Well, for certain, I'd like there to be bespoke technology that's developed so that we can have a solution to measure pain in all children of all ages. And working with the Oxford Innovations Group here, we're able to start developing this technology. I have some experience in technology development. This is the only paper I've ever published with an N of 2 children who are my own. The reason why we stopped is when one of them said, "Is it okay to press the change gravity button?" And the other people in the room suggested that wasn't the ideal thing. So since these early days where we just put a bike cap on the children's head, it's now been really improved. But the aim here is not for children to have to lie in an MRI scanner completely still when they're having their brain scanned, but rather be in a natural environment where they can move around and we can start seeing these responses. I have to say, in this particular case, they were not looking at responses to pain, but indeed maternal touch and comfort. And I like to see that actually both of them seem to respond to my gentle stroking. So all is well there. What else do we want to do? We really want to do some clinical translation. I'd like licensed pain medications to be available for all children. And we've really started working with the FDA and the European Medicines Agency to try and use these as endpoints in clinical trials. And it's my great pleasure that John van den Anker, who's with us today, is going to be the new Newton Abraham Professor in the Department of Paediatrics in 2023, where we're going to work on really trying to drive some change in this field. But my core and the heart of what I really do is the basic science. And so, as well as that, I really want to understand how individual variability occurs in pain between people. Is it innate? Is it our early life experience? Is it the way we're responding to things in our environment? How does the infant brain transition from the early stages until adulthood and the changes that occur in the brain? Can we start to better understand them? And indeed, can we look at the impact of things such as inflammation to see how this affects the nervous system? So while I'm here and have the pleasure to tell you all about this work, I want to thank the fantastic group of people that have actually contributed and done much of this studies. And indeed, a huge thank you to the University of Oxford and the Department of Paediatrics for making it possible to run this programme of research. Thank you very much.
Thank you very much, Rebecca. And it's a little bit frightening to look back and see how experiments were done to test physiology in a completely unphysiological way and fashion. And I think from now forward, I truly hope that future generations won't look back at the way how we do research and come up with the same conclusion. Are there any questions to Rebecca? Charlie? Sorry, you sat down too early.
Thank you very much. That was super interesting. You mentioned that there would be long-term issues with children or babies experiencing pain. So where do you see the future with your research or other people's research in that area? How could that benefit the children's health overall?
So the period we're looking at is when the babies are very young and the nervous system is very plastic, and so it's very vulnerable to external insult. And so I think if you can better manage the pain during that early time, then there's a really possible chance that we'll be able to actually change the developmental trajectory that these children are following. And even from the most simple kind of changes to, even if the pain didn't occur, we don't want these infants to be destabilised. So we can start to look at whether it's affecting their physiology and how these responses, and then going beyond to see, is it actually changing the course of development that some of the children might follow.
There's one question all the way in the back, and then in the first row, Chaz.
Yes, hello, I'm Sir Al Ainsley-Green. And I think with Andrew Wilkinson, we're the longest serving members in the Department of Paediatrics, having joined in 1973. Rebecca, that was a very impressive presentation. Of course, it begs a fundamental question. Why were caring pediatric doctors and nurses oblivious to the possibility that babies could feel pain? And I was delighted to have Sunny Anand as my research fellow to take forward those studies in the 1970s. A quick burst and an unexpected development. After those papers were published, a group of parliamentarians castigated me publicly demanding that I should be sacked from my post, referred to the GMC, etc., because I did unethical studies to see if babies could feel pain. That was completely the opposite of what we tried to do. But there are 2 points I want to make. My career was sidetracked in becoming National Clinical Director for Children in Government and then the first Children's Commissioner for England. I think there are 2 aspects of your profile in the department that could be seized and built on. And it reflects a meeting I attended last Sunday in Rome, a meeting of 100 families with a rare disease that I helped to establish here in Oxford, hyperinsulinemic hypoglycemia, a devastating condition of babies and children. I asked the dipstick question, how many of you families experienced compassionate care in your hospitals? Not one hand went up. In the discussion, they said, yes, we've come across individual doctors and nurses who showed compassion, but our institutions were oblivious to the need for compassionate care. So here's a challenge to you and your department, George. Can you at least acknowledge the importance of compassionate care in what you do? And the second point follows from this, a crucial need for effective advocacy for the needs of children. And just look at childhood today. It's in disarray as a result of COVID. And I think your department has a responsibility to be seen to develop the science of effective advocacy. And your work with pain could be an example of that. So I'm on a bit of a rant here, George, but I do believe that your department, with its stunning science, should be matched by excellence in the science of compassionate care and in the science of effective advocacy.
Thank you very much, Al. I think there's very little to add to that. And I think you made some very important points, which all of us, once having been a patient, know how important it is. Thank you very much. Chaz.
I'm sorry, my comment was very similar. I mean, sort of, you know, we all recognize that maternal hugging, cuddling immediately after birth is so incredibly important, that sort of tactile sensory perception. So I was quite horrified when I saw some of your early slides, Rebecca, and I'm thinking, why on earth did we think that little kids did not feel pain?
I think I can address 2 points in all of the interesting things that have just been said. One is that I don't think very many people really believed babies didn't feel pain. It was more that there was a huge risk associated with the side effects of giving potential drugs. And I think because there was an anxiety about that, it was easier to say there was no evidence about pain. And in terms of your second point, in terms of maternal touch and the importance of care, well, the good news is we're 70 children through a 112-person trial where we're looking at whether stroking babies and activating a population of CT fibres in their skin before painful procedures reduces their pain, reduces the parent's anxiety, and improves the stability of the baby. And simply, if this works, there is no reason why any child anywhere is not stroked for 10 seconds before they're given a painful procedure. So let's see what the results of the trial.
Very good. Thank you very much. And now I'd like to invite you for some tea and refreshments. And we will see you at 25 minutes past the hour back here. Thank you very much.